Welcome to the Deep Dive. Today we're diving deep into Chalazia.
Chalazia. Tiny but mighty. A lot of folks don't realize just how impactful they can be.
Absolutely. And we've got a fantastic guide for our exploration today. We're working off a synopsis put together by Professor Dr. Suhail Sarwar. He's really one of the leading minds in ophthalmology.
Oh yeah, Professor Sarwar's work is top-notch. Always cutting edge, and this synopsis is no exception. It pulls together some really exciting research from all over the world, international journals, the latest findings, the whole shebang.
Now, before we get too far, a quick note for our listeners. This deep dive is geared specifically toward ophthalmologists and other healthcare professionals.
Right. We're going to be using some pretty advanced scientific terminology, so it might not be the best fit for a general audience.
If you do have patients who are looking for information on Chalazia, we highly recommend pointing them to Professor Sarwar's public podcast series.
He's got a whole playlist dedicated to eye diseases that's perfect for the public. Really well explained, easy to understand.
All right, so let's jump into the science. When we say Chalazion, we're talking about a very specific type of inflammation. It's chronic, it's lipogranulomatous, and it's centered on those tiny meibomian glands in the eyelids.
Right, and those three things are key, especially that chronic part. Chalazia, they tend to stick around. They can come back even after treatment. It's a bit of a battle sometimes.
And it's not just about that bump on the eyelid either, right? There are some bigger implications for our patients.
Oh, absolutely. You hit the nail on the head with lipogranulomatous. That describes what we see under the microscope. Clusters of inflammatory cells all mixed up with fat, and that mix, it can really do a number on the meibomian glands.
Those meibomian glands, they're so vital. They're the ones producing the oil that keeps our tears stable.
Exactly. And when they're not functioning properly, the tear film gets compromised. It evaporates too quickly, the eyes get dry, irritated. You know the drill.
It can really impact a patient's quality of life.
No kidding. Dry eye can be incredibly uncomfortable, and in some cases, it can even lead to vision problems.
So what are some of the things that contribute to these pesky Chalazia forming in the first place?
Well, we've got the usual suspects: blepharitis, dry eye disease, and then there are those tiny Demodex mites. They love hanging out in our eyelashes.
Those mites are everywhere.
They are. And recently, we've seen something quite interesting pop up as a potential risk factor: face masks.
Face masks. That's unexpected. Why would face masks lead to more Chalazia?
There's a theory that masks, while of course being crucial for public health, might be messing with the airflow and humidity around the eyes. And that could disrupt the normal function of the meibomian glands. It's still early days in terms of research, but it's definitely something to keep an eye on.
Pun intended.
Maybe a little bit. But seriously, this raises a tricky question for us as clinicians. How do we approach this with our patients? We can't exactly tell them to ditch the masks.
Definitely not. Mask wearing is so important, especially these days.
Right. So it's about finding that balance. We need to protect public health, but we also need to manage individual patient needs.
Absolutely. We can educate our patients about the potential impact on their eyes and stress the importance of proper eyelid hygiene.
Exactly. Good hygiene can go a long way. Now, this research synopsis also dives into some fascinating advancements in diagnostic tools.
Oh yeah, I was excited to talk about this.
The OCLUS Keratograph 5M is really changing the game for us.
It's non-invasive, right?
Totally non-invasive, which is great for patient comfort.
But what's it actually measuring?
All sorts of cool stuff. Tear meniscus height, that tells us how much tear film is present. Then we've got non-invasive tear breakup time. That measures how quickly those tears evaporate.
And I remember reading that it can actually quantify meibomian gland loss, right?
It can, and that's huge. One study using this technology found that patients with Chalazia had significantly higher meibomian gland loss scores. And get this was before they had surgery.
So even before the chalazia becomes super obvious, we're already seeing signs of meibomian gland dysfunction.
Exactly. Early detection is key, and this tool gives us a way to do that.
This is super relevant for us in the clinic. We can identify patients who are at higher risk of developing dry eye or having complications.
Absolutely. It's about being proactive.
So what about treatment? Professor Dr. Sarwar's synopsis also covers the latest in Chalazion treatment, right?
Oh yeah, lots of cool stuff there. We've got the traditional incision and curettage.
Good old INC. Is it still a go-to these days?
It's still a cornerstone, for sure, and it can be very effective. But there are some exciting new approaches emerging. One of them is light-guided tip intense pulsed light.
IPL. Isn't that more of a dermatology thing? I thought it was used for skin rejuvenation.
It is, but it's also showing a lot of promise for treating Chalazia. The IPL targets the inflammation in and around those meibomian glands, and it can even stimulate them to produce healthier oil.
So it's not just about getting rid of the chalazion itself. It's about improving the overall health of the meibomian glands.
Right. A study comparing IPL combined with meibomian gland expression to the traditional INC found that the IPL group actually had a lower rate of Chalazia coming back. And they also saw improvements in tear film stability. Pretty impressive, right?
That is impressive.
Yeah.
So less invasive and potentially fewer repeat procedures. It sounds like a win-win for our patients.
I think so. And it's definitely something that all ophthalmologists should be aware of. It's definitely worth considering, especially for patients with a lot of inflammation. Now, there are other interesting techniques being explored as well. Have you heard of diathermy thermocoagulation?
It sounds intense. What is it?
Basically, it uses heat to remove the chalazion. Cauterize and remove.
And how does it compare to IPL or the traditional INC?
It's still early days in terms of research, but one study that looked at diathermy thermocoagulation didn't find any complications. So that's encouraging, something that deserves more attention, I think.
I agree. Now, no matter which technique we're using, surgery on the eyelids can be tricky, especially in those mucosal areas, like the inner surface of the eyelid.
Oh yeah, it's delicate work for sure. Visualization can be tough, and there's always the risk of bleeding.
Traditional Chalazion clamps, the ones we use to stabilize the eyelid, can help, but they can also cause problems if they're left in place for too long.
Right, you don't want to cut off the blood flow, too much pressure for too long, and you end up with tissue damage. Ischemia, no good.
That's where a modified Chalazion clamp comes in.
Exactly. It's designed to provide stability without compromising blood flow. And get this, it's not just for eyelids. They've used this modified clamp in procedures on the nasal mucosa, earlobes, lips, even web spaces. It's pretty versatile.
That's remarkable. So we've got new diagnostic tools like the Keratograph 5M, new surgical techniques like IPL, and even innovative tools to make those tricky procedures a bit easier. It's a pretty exciting time to be in ophthalmology.
It really is. We're making strides on so many fronts. What stands out to you as particularly impactful?
I think for me, it's the emphasis on early detection. Being able to identify those subtle signs of meibomian gland dysfunction before they turn into big problems, that's huge.
I completely agree. Early intervention is key.
So before we move on to those all-important differential diagnoses, I want to pause for a moment and ask our listeners to reflect. How are these new insights shaping your approach to Chalazion diagnosis and management? Are you incorporating these advancements into your practice? It's a lot to think about.
It is, but that's what makes this field so rewarding. We're constantly learning and evolving, and ultimately, it's all about improving patient care.
Absolutely. Now, onto those differential diagnoses. They're crucial, right?
Oh yeah, absolutely crucial. Sometimes, what looks like a straightforward chalation can actually be something else entirely. We've got a great case study that illustrates this point. It involves a young man who came in with what appeared to be a chalazion, but further investigation revealed something much more serious.
Eyelid angiosarcoma, right.
You got it. That case really underscores the importance of maintaining a high index of suspicion. We can't get complacent.
So what are some of the red flags we should be watching for? The things that should make us think twice about that diagnosis of a simple chalazion?
Atypical presentation is always a big one. Is it growing rapidly? Is the color unusual? Is it not responding to the usual treatments? Those are all signs that we need to dig deeper. And in those cases, a biopsy is essential.
A biopsy can give us that definitive answer. It's better to be safe than sorry.
Couldn't agree more.
Now, you know those versatile Chalazion forceps we were talking about earlier?
Yeah.
Turns out they're not just useful for Chalazion excision, they've been used for other procedures as well, like labial salivary gland biopsies.
LSGBs.
Yep.
Interesting.
One study compared the traditional LSGB technique to a modified technique using those Chalazion forceps. And guess what? The modified technique had a smaller incision size, shorter operative time, less blood loss, and lower pain scores. And all of that without compromising diagnostic accuracy.
That's fantastic. Less invasive, less pain. That's what we want for our patients. It's amazing to see these innovations happening.
It really is. Now, let's switch gears for a moment and talk about a condition that can sometimes be mistaken for a chalazion. Apocrine hydrosystema.
Those can be tricky. They're benign, but they can look quite similar to Chalazia, especially early on.
We've got a case study that highlights this perfectly. It's about a young woman who came in with a growing nodule under her eyelid. She'd had multiple Chalazia in the past, so naturally that's what everyone was thinking, but this time it was different.
So what was it?
Turns out it was an apocrine hydrosystema. And what's interesting is that she had had several INC procedures for those presumed Chalazia in the past. It makes you wonder if those procedures could have played a role in the development of this hydrosystema.
Interesting. It's possible. Repeated trauma to the eyelid, even from a relatively minor procedure, could potentially trigger the formation of a cyst.
It's a good reminder for us to be mindful of the potential long-term effects of our interventions.
Absolutely. Even seemingly minor procedures can have unintended consequences down the road.
And this case also highlights the value of using the right diagnostic tools. Immunohistochemistry, for example, can be really helpful in these situations.
It can. It allows us to look at the proteins in the tissue and really differentiate between different types of lesions. And in this case, the immunohistochemistry results were suggestive of IgG4-related disease.
IgG4-related disease, that's a mouthful.
It is. It's a systemic inflammatory disorder that can affect various organs, the eyes, the salivary glands, the pancreas. It can be quite serious.
So this seemingly simple eyelid lesion could actually be a sign of something much bigger going on in the body.
Exactly. It's a reminder that we're not just treating eyes, we're treating people. We need to be thinking holistically.
Now, before we delve into the fascinating world of metabolic insights and their connection to Chalazia, I want to touch on one more case study. This one involves a patient with a history of mantle cell lymphoma. It's a type of cancer that affects the lymphatic system. And during his treatment, he developed a lesion on his eyelid.
Okay, this is intriguing.
At first, they thought it was benign, maybe a chalazion or something similar. But because of his lymphoma history, they decided to do a biopsy just to be safe.
And it turned out to be.
Squamous cell carcinoma, skin cancer.
Wow, so double whammy for this patient. But thankfully, they caught it early, thanks to that biopsy.
Exactly. This case really emphasizes the importance of considering a patient's medical history when we're evaluating eyelid lesions. It can really guide our decision-making.
Absolutely. If someone has a history of skin cancer, we're going to be much more cautious.
Now, I know we've been focusing a lot on the technical aspects of Chalazia, diagnosis, treatment, all that, but we can't forget the human side of it all. These conditions can really impact a patient's self-esteem, their confidence.
Definitely.
We've got a case study that really drives this home. It's about a patient with metastatic gastric carcinoma.
Stomach cancer that had spread.
That's right. And he developed this firm lesion on his upper eyelid, which caused severe ptosis.
Drooping of the eyelid.
Exactly.
Oh, I can only imagine how distressing that must have been for him.
It must have been incredibly difficult. And this case is a reminder for all of us to approach our patients with compassion.
To listen to them. To validate their experiences.
Yes. Sometimes that's the most important thing we can do.
Well said. So, we've talked about the importance of patient education. But how can we really empower our patients to take control of their eye health, especially when it comes to Chalazia?
I think technology has a huge role to play here. Imagine apps that allow patients to track their symptoms, monitor their eyelid hygiene. They could even receive personalized reminders based on their individual risk factors.
Oh, that's a fantastic idea. Give them the tools and the knowledge they need to be proactive.
Exactly. And it would also improve communication between patients and their doctors, a real partnership in care.
I love that. A collaborative approach.
Now, I know we've touched on the link between face masks and Chalazia earlier, but it's worth emphasizing again.
For sure.
Mask wearing is still crucial, but we need to educate our patients about the potential impact on their eyes. Encourage good hygiene, taking breaks when possible. It's all about finding that balance.
Right. We can't abandon those public health measures, but we also need to be aware of the potential downsides.
We can also talk to them about other risk factors, blepharitis, dry eye, rosacea. Helping them manage those conditions could help prevent Chalazia from developing in the first place.
Definitely.
Now, before we move on, I want to mention one more interesting finding from the research. This one's about smoking and Chalazia.
Smoking and Chalazia.
Really? It sounds strange, but a large study actually found that smokers were more likely to be diagnosed with Chalazia.
Huh. I wonder if it has to do with the inflammatory effects of smoking. We know smoking increases inflammation throughout the body. Maybe it's not so surprising after all.
It's another reason for our patients to quit, not just for their overall health, but for their eye health too.
It all comes back to that holistic approach, doesn't it?
It really does. Okay, ready for our final exploration?
Hit me with it.
Genetics.
Ah, the building blocks of life. What have they found out about genetics and Chalazia?
They've been using a technique called genome-wide association studies, GWAS. Basically, they scan the entire human genome looking for variations that are linked to specific diseases.
So they're looking at the whole genetic picture. That's amazing.
It is, and they've made some really interesting discoveries. For example, they found several genetic variants that seem to increase a person's risk of developing Chalazia.
So some people might just be more predisposed to getting them. Fascinating.
It is. And this kind of information could pave the way for personalized medicine, tailoring treatments based on a patient's unique genetic makeup. That's the future.
That's incredible to think about.
And it's not just about identifying those risk factors. Genetic research is also helping us understand the biological processes behind Chalazia.
Oh, so?
Well, one study looked at a gene called DST. It's involved in cell adhesion and skin barrier function. And they found that certain variations in this gene were linked to a higher risk of Chalazia.
So maybe people with these variations have a weaker skin barrier, making them more vulnerable to Chalazia. That makes sense.
It does. And it opens up some exciting avenues for research. Could we develop treatments that target these specific genetic pathways or strengthen the skin barrier to prevent Chalazia? It's really mind-blowing stuff.
It is. Now, you mentioned another study that used a slightly different genetic approach, Mendelian randomization, right?
That's the one. And this study focused on blood lipid levels and Chalazia risk.
Blood lipids, like cholesterol and triglycerides.
Exactly. And they found a positive causal association between higher triglyceride levels and an increased risk of Chalazia.
Interesting. So people with high triglycerides might be more prone to developing Chalazia.
That's the hypothesis.
Yeah.
And it raises some really important questions about lifestyle factors. Could managing blood lipid levels through diet, exercise, or medication help reduce the risk? It's an area that needs further exploration.
Absolutely. And it reinforces the importance of a holistic approach to patient care. Genetics, lifestyle, medical history, it all plays a role.
It's all connected.
It is. Well, this has been an incredible discussion so far. It's amazing how much we're learning about Chalazia.
I agree. And we're not done yet. We'll be back soon with part 2 of our deep dive.
Can't wait. I'm ready for more. Ready for more Chalazion insights.
Always. That last discussion about genetics and triglycerides really got me thinking. There's so much more to these little Chalazia than meets the eye.
Right. It's fascinating how much research is happening, and now we're going even deeper, ready to talk about artificial intelligence.
AI, like the stuff that's taking over the world. What's that got to do with Chalazia?
Well, maybe not taking over the world just yet, but AI is definitely showing promise in ophthalmology, specifically for helping us diagnose Chalazia more accurately.
Okay, I'm intrigued. Tell me more.
So, you know how sometimes a Chalazion can look like something else? Something more serious?
Right, like that case of eyelid angiosarcoma we discussed earlier.
Yeah.
Scary stuff.
Exactly. Well, researchers are exploring whether AI can help us differentiate Chalazia from other eyelid conditions, to avoid those misdiagnoses. And the early results are pretty encouraging.
So the AI is like a second opinion, helping us make sure we're not missing anything.
Sort of. It's more like a super-powered diagnostic tool. One study looked at using AI-generated images to train students in diagnosing both Chalazia and sebaceous carcinoma.
Sebaceous carcinoma, that's another eyelid tumor that can be tough to spot, right?
Right, it can really mimic a Chalazion. So in this study, some students learn using traditional methods like lectures and textbooks, while others use these AI-generated images.
So they were basically learning from pictures created by AI. That's wild. How did they do?
Both groups improved their diagnostic accuracy after the training, but here's the interesting part. The group that trained with AI images got significantly better at correctly diagnosing Chalazia.
So the AI was particularly good at picking out those classic Chalazion cases. What about the sebaceous carcinoma?
For that one, the group with the traditional training actually performed better.
So it seems like AI might have its limitations. Maybe it's not as good at recognizing those more subtle or atypical cases.
That's a possibility. The researchers think it might have to do with the data that the AI is trained on. If it only sees a limited range of examples, it might struggle with those more nuanced variations.
That makes sense. You need to teach the AI what to look for, just like you would with a human student. Garbage in, garbage out, as they say.
Exactly. But the potential is definitely there. As these algorithms are refined and trained on more diverse data sets, their accuracy will likely improve. And the study also found something else really interesting. The students who trained with the AI images were actually able to make diagnoses much faster.
So AI could not only improve our accuracy, but also make us more efficient. That's huge in a busy clinic.
I know, right? Imagine being able to confidently rule out a serious condition like sebaceous carcinoma right there in the exam room. It would be a game changer.
It would. But I guess we have to remember that AI is just a tool. We can't let it replace our clinical judgment.
Absolutely. We still need to use our knowledge, our experience, and our critical thinking skills. The AI is there to assist us, not to take over.
Well said. Speaking of honing those skills, I was really interested in Professor Dr. Sarwar's mention of the resident-centric Chalazion clinic. It's a fantastic idea for training, isn't it?
It is like a dedicated boot camp for learning how to do Chalazion incision and drainage. Residents get tons of hands-on experience under the supervision of an attending physician.
I love that.
Yeah.
It takes a procedure that's often considered pretty basic and turns it into a valuable learning opportunity.
Hmm.
And it seems like it's really effective.
Oh, definitely. One study found that after implementing a Chalazion clinic, residents were performing almost 3 times as many procedures each year. That's a lot of practice.
That's amazing. I wonder if we could apply this model to other common procedures, get residents more comfortable and confident with those bread and butter skills early on in their training.
It's definitely worth considering. The more experience they get in a controlled environment, the better prepared they'll be for those real-world challenges.
I agree. Now let's shift gears a bit and talk about another condition that can sometimes be confused with a chalazion. Have you ever encountered apocrine hydrosystema?
Oh, those can be tricky. They're benign cystic lesions, but they can look a lot like a chalazion, especially at first.
Professor Sarwar included a case study about a young woman who came in with an eyelid nodule. She had a history of multiple Chalazia, so everyone assumed it was another one. But it turned out to be an apocrine hydrosystema.
And I bet she'd had a few INC procedures in the past, right?
She had several, in fact. It makes you wonder if all that repeated manipulation of the eyelid tissue could have played a role in the hydrosystema forming.
It's certainly possible. Trauma, even from minor procedures, can sometimes have unintended consequences. It's something to keep in mind.
It is. And this case also shows how important it is to use the right diagnostic tools. Sometimes we need to go beyond the clinical exam. Things like immunohistochemistry can be really helpful.
Absolutely. Immunohistochemistry can help us identify the specific types of cells present in a lesion, which can really guide our diagnosis. And in this case, the results suggested a possible connection to IgG4-related disease.
IgG4-related disease. Refresh my memory. What is that again?
It's a systemic inflammatory condition that can affect a bunch of different organs: the eyes, the salivary glands, even the pancreas. It can be pretty serious.
So this woman's seemingly simple eyelid lesion could actually be a sign of a much larger issue going on in her body. That's a lot to take in.
It is. It really underscores the importance of thinking holistically. We can't just focus on the eyes. We need to consider the whole patient.
Well said. Now, remember earlier when we talked about Sjögren's syndrome, another autoimmune condition that can affect the eyes. The research synopsis also dives into some of the factors associated with Sjögren's diagnosis.
Right. It seems like dry eye disease and a high titer of anti-nuclear antibodies were pretty strong predictors.
So if we see those things in a patient, we definitely need to be thinking about Sjögren's as a possibility.
Absolutely. Early diagnosis and management are crucial for preventing complications. We can't afford to miss it.
I agree. Now, one more case study before we move on. This one involves a patient with a history of mantle cell lymphoma.
Mantle cell lymphoma, that's a type of cancer, right?
Yes, it affects the lymphatic system. And during his treatment for the lymphoma, he developed an eyelid lesion. At first, they thought it was benign, maybe just a chalazion. But because of his cancer history, they decided to biopsy it just to be safe.
I'm guessing it wasn't a chalazion after all.
You're right. The biopsy showed it was squamous cell carcinoma, skin cancer.
Wow, that's a double whammy. But at least they caught it early.
They did. And that's the takeaway here. We always have to consider the patient's medical history. It can completely change how we approach an eyelid lesion.
Especially when it comes to deciding whether to biopsy or not. In this case, that biopsy might have saved his life.
Now, I know we've talked a lot about diagnosis and treatment, but we can't forget the impact these conditions have on our patients' lives. A chalazion might seem like a minor thing, but it can really affect their self-esteem and their confidence.
Absolutely, especially if it's causing discomfort or affecting their vision.
Professor Sarwar included a really poignant case study about a patient with metastatic gastric carcinoma, stomach cancer that had spread.
Oh, that's heartbreaking.
It is. And on top of everything else he was going through, he developed this firm lesion on his eyelid that caused severe ptosis.
Drooping of the eyelid.
Right. I can only imagine how difficult that must have been for him, both physically and emotionally.
It's a powerful reminder that we need to approach our patients with compassion and empathy. Sometimes the most important thing we can do is just listen to them and validate their feelings, Let them know we understand what they're going through.
I couldn't agree more. Now let's talk about patient education for a moment. How can we empower our patients to take a more active role in managing their eye health, especially when it comes to Chalazia?
Well, we can start by educating them about the potential risk factors. Things like blepharitis, dry eye disease, rosacea. If they can get those conditions under control, they might be less likely to develop Chalazia in the first place.
That makes sense. Prevention is always better than cure.
Exactly. And we can also talk to them about those lifestyle factors we discussed earlier. Managing blood lipid levels through diet and exercise, quitting smoking if they smoke. Those things can make a difference.
Right. It's all about those healthy habits.
And then there's the issue of face masks.
Ah, yes. The double-edged sword of modern life. Protection from infection, but potentially a risk factor for Chalazia.
Exactly. We can't tell people to stop wearing masks, but we can encourage them to take breaks when possible, to practice good eyelid hygiene, and to let us know if they notice any changes in their eyelids.
It's about finding that balance between public health and individual needs.
Right. And I think it's also important to emphasize that even though Chalazia can be frustrating, they're usually not serious. Most of the time, they can be managed effectively with conservative treatment, so there's no need to panic.
That's a good point. Reassurance can go a long way. Now, before we wrap up this section on risk factors and prevention, I want to highlight one more interesting finding from the research.
Oh, what is it?
It seems there's a connection between Chalazion diagnosis and income level.
Really? That's surprising. I wonder what the explanation could be.
I don't think the research delved into the reasons behind it, but it definitely sparked my curiosity. Perhaps people with higher incomes have different access to health care. Maybe they're more likely to seek treatment for minor eye issues. Or maybe it has something to do with lifestyle factors that are more common in certain socioeconomic groups.
It's an interesting question, definitely something to explore further. It just goes to show that there's always more to learn, even about a seemingly simple condition like a Chalazion.
Absolutely. Well, I think we've covered a lot of ground in this section. We've explored risk factors, prevention strategies, and some of the complexities that can arise when diagnosing and managing Chalazia.
It's been a fascinating discussion.
It has. And we're not done yet. In the final part of our deep dive, we'll be exploring some truly cutting-edge research.
Oh, like what?
Think stem cells, gene editing, nanotechnology. The future of Chalazion treatment is looking pretty exciting.
Wow, I can't wait to hear about it.
We'll see you back here soon for the final installment of the Deep Dive. Welcome back to the Deep Dive. We've journeyed through diagnostics, treatments, genetics, even the impact of face masks on Chalazia.
We've covered a lot of ground, that's for sure, but there's still so much more to uncover.
Exactly. Professor Dr. Sarwar's synopsis really emphasizes the need for more research into the long-term effects of Chalazia.
That's a really important point. We tend to focus on resolving those immediate symptoms, like that bump on the eyelid. But what about the bigger picture?
Right. Could those repeated bouts of inflammation and gland blockages have lasting consequences? Could they increase the risk of chronic dry eye? Or even affect vision down the line?
Those are questions we need answers to. We need those long-term studies to really understand the full impact of Chalazia.
Imagine being able to counsel our patients about the potential risks and benefits of different treatments, not just for now, but for years to come. That would be huge.
It would completely change how we approach patient education, and it would help patients make more informed decisions about their care. Now, speaking of exciting possibilities, I was fascinated by the section on stem cell therapy.
Stem cells. It feels like they hold the key to so many medical breakthroughs. Could they really help us treat Chalazia?
It's definitely an area with huge potential. Think about it. Chalazia can lead to damage and loss of those precious meibomian glands.
And that disruption of the tear film can cause all sorts of problems. Dry eye, irritation, even vision changes. If we could use stem cells to regenerate those damaged glands, that would be incredible.
It would. It's like hitting the reset button on meibomian gland function. And it's not just a pipe dream. We're already seeing some promising results with stem cell therapy for other eye conditions.
Right, like macular degeneration and corneal damage. So it's not so far-fetched to think that stem cells could play a role in treating Chalazia, too.
Not at all. It's still early days, but the research is moving forward, and the possibilities are pretty mind-blowing.
Now, before we wrap up our deep dive, I want to circle back to something we've touched on a few times. Patient empowerment.
It's so important.
We need to go beyond just educating our patients. We need to give them the tools and resources to truly take control of their eye health.
I agree. What do you have in mind?
I'm thinking technology could play a huge role here. Imagine apps that let patients track their symptoms, monitor their eyelid hygiene, even get personalized reminders and advice based on their individual risk factors.
I love that. It puts the power in the patient's hands, and it
Yeah.
keeps them engaged in their care.
Exactly. It's about fostering that partnership between patient and doctor, working together to achieve the best possible outcomes.
Well, I think we've come full circle. We've explored the latest research, the challenges, the innovations, and the importance of patient-centered care. It's been quite a journey.
It has, and I hope our listeners have found it as insightful and thought-provoking as we have. This is a field that's constantly evolving, and there's so much more to discover.
Definitely. I'm leaving this deep dive feeling energized and excited about the future of Chalazion research and treatment.
Me too. And a huge thank you to Professor Dr. Suhail Sarwar for compiling this incredible synopsis. His work is truly pushing the boundaries of what we know about Chalazia.
Absolutely. His dedication to advancing the field is inspiring.
And to our listeners, we encourage you to stay curious, keep exploring, and never stop learning. The more we understand about Chalazia, the better equipped we'll be to provide the best possible care for our patients. Thank you for joining us on this deep dive into the fascinating world of Chalazion research. We'll see you next time on The Deep Dive.